Good afternoon, everyone. I'm Sam Thompson. I'm a program manager here at the US-UK Fulbright Commission. Thank you for joining us for this public event in our Across the Pond webinar series. This has been a new and exciting initiative that we've been running over the course of the summer of transatlantic conversations. We're bringing together two Fulbright scholars, one from our UK cohort and one from our US cohort, to discuss the intersection of their research interests. It's great to connect not only our two scholars, but also you, our audience, to be a part of our mission of civic engagement. Tonight, we're talking about cancer. Cancer is one of the leading causes of death worldwide, and in 2020, it accounted for nearly 10 million deaths. Diagnosis remains crucial to cancer treatment. Raise public awareness of cancer signs and symptoms in conjunction with screenings and physical examinations. These early measures can make all of the difference. Tonight's scholars will draw on their respective experience in cancer diagnostics to explore the challenges facing us today, outlining key developments in treatment and healthcare. We'll also touch on how data is used to study cancer. Before I introduce our two scholars this evening, just a little bit of housekeeping on the event itself. We are going to be recording tonight's webinar. You should have had a little message pop up when you joined the call to say that we'll be recording. What that means is we hope to publish this online on our website not long after the event. So if you miss anything or there's a point that you think would be interesting to go back to and listen to what our scholars had to say, you'll be able to catch up on that on the recording. We've also recorded all of our previous events, so we're starting to build a bit of an archive of these events for you to go back. If this is perhaps your first time at one of these webinars, you might want to go back and check out some of our early ones. We've got some really fascinating topics that we've covered. And we also have events in the future, and if you're not able to make those, you'll be able to find those online in the archive later. We also encourage you to get involved. This is about connecting you with our scholars and their work that they do as part of their Fulbright grants. So I encourage you throughout the evening tonight, throughout the webinar, to ask your questions. We have a Q&A box, and that's where you should put your questions. And we'll try and get to those as they become relevant in the conversation. Don't worry about saving your questions to the end. I'll be keeping an eye on the Q&A box as we go. So be sure to get your questions in, and we'll try and get to as many as we can. And then to get to our scholars for the evening, we're joined by Larry Kessler, who is a professor in the Department of Health Services in the School of Public Health at the University of Washington. He has over 40 years of experience in health services research, and his work in cancer surveillance at the National Cancer Institute of NIH has substantially changed the way in which the US performs their cancer surveillance. We're also joined by Niyati Lobo, who is a final year urology trainee here in the UK with interest in robotic surgery and bladder cancer. She is our Fulbright Urology Foundation scholar and is currently undertaking her research at the Anderson Center in Houston, Texas. Larry, how are you doing this evening?
I'm doing well, thank you, and it's morning for me.
Well, I hope it's a great day ahead of you as well. And Niyati, how are you?
Yeah, very well, thank you. I'm really happy to be here with you guys.
Great. So if we can get started, Larry, could you talk a little bit, drawing on some of that experience of how cancer and the study of cancer has really changed over the past 4 or 5 decades?
Sure. Thank you, Sam, for that introduction. I'm really pleased to be here. And I know we have a very, very diverse audience because I've actually listened to some of the Across the Pond sessions, and it's very clear that I'm talking to a widely divergent group. So I'm going to start off with some basics. And if I mention information that people are aware of, I apologize for talking about things you already know. But there's a lot of information here that I think Niyati and I can talk to you about today. So I'm going to delve back into time a little bit and talk about cancer from the last century. It's a wide variety of diseases, and we'll talk about that in a few minutes. But just in a very big picture, in 1970, 1975, roughly, when in the US, we had something called the War on Cancer start, survival from cancer was a challenge. At least 50% of persons who were diagnosed with cancer around 1970 did not live even 5 years. That's changed, fortunately. Cancer has had a lot of changes in screening and prevention and diagnosis. We'll talk about many of those. And so now, as of around 2020, the estimated 5-year survival rate for cancer patients is around 70-ish%. That still means 30% of persons die with this dreaded disease within 5 years, and we'd like to make that go down even further, but it is quite an improvement. And how do we know that? Well, one of the ways we know that is the way we track cancer. And we use a lot of different ways to track these public health statistics. One of the major tools that Niyati and I will talk about today are cancer registries. Cancer registries are ways in which we collect data. And in certain parts of the world, certain parts of the United States, it's a requirement when a cancer is diagnosed to report to the local public health agencies, and those are collected together, and we can monitor what's going on with cancers. Now, one of the reasons this is challenging is that cancers not only are rapidly fatal, but they also are very varied, okay? And it used to be 5-6 decades ago, the way we characterized cancers were by organ systems: lung cancer, breast cancer, leukemias, cancers of the blood organs and blood generating organs. And that still is the major way we classify, but we've learned over the past few decades that each of those cancers is actually subdivided into many, many different types of disease. And we're going to talk about some of those today. And the registries help us track some of that information. And as we get more and more sophisticated information about finding out what types of cancers those are, then we can use those data to tell us more about the ways in which cancer really informs us. And we use these registries for all kinds of information, not only to track the new cases of cancer and how they survive, but what factors relate to the survival of cancer. And good examples, even recently, as much as we'd like to think we made progress, a publication a few years ago by Libby Ellis in California looked at the California State Registry and tracked what was going on over time. And the survival improvements that I talked about early in my few comments here look like they work for people who are insured in the US with Medicare or with private insurance, but these survival gains were almost non-existent for people on public assistance or with no insurance. And so registries is a way we can find that out and discover that we clearly have public policy challenges ahead of us. And so that's just one of the ways we look at these data. And I'm going to stop now and turn it over to Niyati, and she can talk about bladder cancer as a specific example of what we're doing. I'll come back later and we'll talk more about specifics on diagnostics.
Thanks, Larry. So just to clarify, because it's not always clear, I'm a urologist in training. So a urologist is a doctor that specifically is interested in diseases of the kidney, the bladder, and male reproductive organs. Now, I have a specific interest in bladder cancer for a number of reasons. I think one of the main reasons is because it's a really interesting time in bladder cancer at the moment. We had a really long period of time, about 30 years or so, where the survival for patients with bladder cancer, that's advanced bladder cancer, really didn't change. But we've had a lot of developments recently in the last decade or so, which means we've made huge progress in understanding the disease, how it behaves, what new treatments might work for it. So bladder cancer used to be known as the Cinderella cancer for that reason. But it's really nice that things are shifting, and we're learning a lot about the disease itself. So Larry talked a little bit about cancer registries, and I am using one of these registries for my Fulbright project to look at bladder cancer. But I'm just going to give you a little bit of background about bladder cancer, because I think it helps to put the whole project into perspective. So a typical patient might come to see a urologist because they've noticed blood in their urine. Now, blood in your urine can happen for a wide variety of reasons, but if you have painless blood in your urine, that can be a sign of bladder cancer. So if someone comes to see us with this symptom, what we will do is we'll place a camera into their bladder and look for bladder tumors. Now, if we see a bladder tumor, what will then happen is that the patient will need an operation to remove the bladder tumor, and you might think, okay, well, great, that's it, end of story, the tumor's out, patient's fine. But that's not really the case. And the reason for that is because bladder cancer it has a tendency to return. So I normally tell my patients that it's like weeds in the garden. You may get rid of them, but they can come back again. So what do we do to manage that? Well, we will place patients on a program of regular surveillance. So that will mean that the patient, after their initial operation, will come back at regular time intervals, more frequently to begin with, and then the intervals get longer and longer if they have good outcomes. But that's expensive for healthcare systems to bring patients for these camera examinations or endoscopies. But if you forget about the cost to the healthcare systems, that's actually also a huge burden that you're placing on patients. So not only are these camera examinations uncomfortable, they're also anxiety inducing. So if you think that every time you're going into hospital for your camera test, in the back of your mind you're always worried, well, what if it's come back? And so it's not great for patients. And actually, bladder cancer has the highest lifetime cost of all cancers because of the need for repeated surveillance and also imaging as well. And now there are two types of bladder cancer. There's bladder cancer, which just is confined to the lining of the bladder. But if patients are really unlucky, they may have a cancer that has gone into the muscle of the cancer. And sometimes patients can have superficial bladder cancers, the ones that are just confined to the lining, but over time they develop into ones that may invade the muscle. And that's a really serious problem. That means a really big operation to remove the patient's bladder called a cystectomy. So we know this much about bladder cancer. And what we also see when we look at patients with bladder cancer is, for some reason, women tend to do worse than men, and we really don't know why that is. There are several different theories. One theory that's really interesting, but it's very difficult to prove, is this sort of association between urinary tract infections and bladder cancer. So women often get urinary tract infections, much more often than men, and urinary tract infections can give you blood in the urine. So patients can often see their GPs with symptoms of urinary tract infections, blood in the urine, and might get treated for a UTI several times before the patient and the physician thinks, oh, maybe there's something more going on here, and maybe I should go see a urologist. But at that point, there's been a significant amount of time where this patient has been treated for a urinary tract infection, but actually there's something going on. So that's one of many reasons why we think women may present with more advanced disease later on. But ultimately, we don't know why this happens. So my project is to use a cancer registry, and the registry I'm using is the SEER registry. So that stands for Surveillance, Epidemiology and End Results. And it's a cancer registry that's specific to the United States. And it's a really powerful tool because it collects data on a lot of information. So you get patient demographics, you'll get comorbidities of the patient. So whether they've got diabetes, heart disease, you will get the details about the tumor itself, the details about the treatment, and then whether the patient's dead or alive. So the advantage of this registry is that you can really use it to look at trends at a population level. America is such a huge country. And so the advantage of this is that it really gives you a big picture of what's happening throughout the country. And I'm using this database currently to look at differences in survival outcomes and also treatment patterns between men and women with the superficial bladder cancer. So I'm interested in finding out, first of all, do men and women do the same in terms of outcomes from the cancer? When the tumors come back, that's what we call recurrence. So is the recurrence rate of the cancer the same between men and women? Do more men progress onto muscle invasive disease compared to women? And I also want to know, are there differences in the treatment being received? Now, we know that there are disparities in cancer treatment across socioeconomic status, across race, and across sex in some cases. So I want to know, are men and women having the same access to certain therapies that we use bladder cancer? So that's how I'm using the registry to do my Fulbright project. And it's really exciting, and I'm looking forward to sort of getting the results and looking at this. And maybe I can turn back to you, Larry, and ask you a little bit about your project.
Sure. Thanks. Sam, are there any questions? We're happy to be interrupted by.
I have quite a basic question, but I figured it was worth asking for the sort of nature of this as a look at both sides of the Atlantic. So, Niyati, the specific registry you're looking to use is in the US, but are there registries for other kinds of cancers kept in the UK? Is this a practice that is done so differently in the US that it's important for researchers like yourself to have access to it? Or is it that your specific field is very US centric and someone from the US might actually need to use a registry here in the UK, for instance, to get a broader picture of
there are certainly cancer registries in the UK, but certainly not one, as far as I'm aware, that captures the same level of information as the SEER database, and also gives you that information over a long length of time. But I think Larry might be able to shed some light on that as well.
Yeah, so the SEER registries are generally recognized as the world standard for collecting cancer data, and they began with the first, second, and third cancer surveys way back in the 1930s, 40s, and 50s. And by the time 1970 rolled around, we were covering at the National Cancer Institute, where I was, around 14% of the US population. Now it's way above that. It's, I think, around 30% of the US population, which is quite large, and a level of detail that's unmatched. And the way that the data are collected by manual abstraction, the level of detail in the SEER registries is pretty exceptional. There are registries in the UK, there are registries in most of Europe. The Scandinavian registries are particularly good for a number of medical conditions as well.
Thank you.
Other questions, Sam?
None from me, and none from our audience so far, but so please do carry on. I just figured it would be worth adding that context.
Oh, absolutely. So I want to take off from what Niyati said, and we'll go back and forth about this because she asked me about my project, and it gives me an opportunity to talk about cancer diagnostics. And she mentioned them a few times. And I want to talk about for a moment, to give the audience an appreciation, that there are a number of technologies that are used to look into the body to try to figure out if you have cancer. Some of those are actually used to try to detect cancer early. And many of those we try to use with healthy populations, and that's in the term of cancer screening. So women may be aware of a mammography, and women over the age of 40 or 45 or 50, depending where you are and what you believe about the evidence, are recommended to go in for a breast cancer exam. It's a radiologic exam, imaging exam, where you're trying to detect breast cancer before it becomes symptomatic. And most cancers, if you detect them early, tend to have much better prognoses. The survival is much longer. There's some complication understanding how that actually works, because sometimes you detect cancer early and it doesn't improve or doesn't work well, but generally that's what the aim of screening is. And there are also a few blood tests, particularly for prostate cancer, something called the prostate-specific antigen, which can be used for screening as well, although the evidence for whether that's effective or not is somewhat controversial. What I'm doing is actually looking at a number of these technologies at the time of cancer diagnosis. So what Niyati mentioned, she mentioned if you have blood in your urine and you come in to see your doctor, it could be a sign of bladder cancer. So there we might use a variety of diagnostic technologies to figure out whether the patient does have cancer. And then further what subtype of cancer they have. And there are different ways to look at different cancers. I'm very interested in genomic or molecular alterations within the cancer tumor that might lead to figuring out what the prognosis is of the cancer, how long someone might live, or are they likely to recur, or what treatment might work best. And only recently, in the last couple of decades, are we able to actually tell something about the somatic nature of the tumor and how that might respond to therapy, particularly the recent immunotherapies, which for certain cancers have been quite successful, or for certain subtypes of cancer that have been quite successful. And so what we try to do is take a look at how those data are being collected in terms of diagnostics and what the evidence is. And my particular projects are in two very different directions, but both in the diagnostic area. One area I'm looking at is the ways in which these new cancer diagnostics don't have enough evidence to be used effectively in the community. And that's really important because the regulatory bar that is used to put diagnostic technologies on the market almost anywhere, Europe, US, elsewhere, is relatively low, that we expect companies to show that you can detect a biological phenomenon, but it doesn't necessarily mean that's going to be clinically useful. So that's a relatively low regulatory bar for these technologies. So I'm very interested in looking at the way the technologies have gotten on the market and what we can learn about whether they really are clinically effective. Are they really diagnosing cancers accurately? Are they helping us prescribe the right treatments? Are the right people getting the diagnostic technologies? I mentioned earlier the registry evidence about insurance, and that people are advantaged if they have insurance in the United States, for example, and not if you don't. And that probably is the case with diagnostics. That's not been looked at extensively, but that's one of the parts of my project I'm interested in. And another one, which is very relevant to the UK, has to do with a new set of diagnostic markers, multi-cancer early detection markers. And these are potentially being used in primary care. And there's some brand new companies, I don't want to mention to endorse companies, that believe they have markers that can, with a very small amount of blood, detect the potential that you may have many cancers in your body and then begin a diagnostic investigation. And there are ways in which the US would take those on board, and the UK takes them on very differently. They have a process called a 2-week wait process, which is a way of delaying a little bit rather than jumping right on top of symptomatology, and the way in which these multi-cancer early detection markers, they may have incredible promise, but they also could get a lot of people into the healthcare system suddenly for diagnostic processes. And we have to look at that carefully to make sure that it's being done within the context of the health system that advantages the patients and their providers. And then I'm going to say one more thing about diagnostics, and maybe either you have questions or you can go back to Niyati, and that has to do with something that she mentioned, which is recurrence. One of the ways these technologies are used is to monitor patients over time to see whether the cancer is recurring. And you want to know that as soon as possible. Almost all cancers are defined by the uncontrolled growth of tumor cells. And they take over the organs, they metastasize to other organs, they metastasize to the bone, very painful, very challenging. And that's the way in which they kill people. And so you want to catch recurrences as early as you can. And one of the things to figure out, and we can talk about this in bladder cancer, is what technologies do you use to look for cancers and how often do you do this? Because as Niyati said, it's very expensive. So trying to balance for someone who has cancer, knowing exactly what they have and then how to monitor them over time, that's a challenge for us as clinicians and health services researchers. What do you think about that for bladder and other related urologic cancers, Niyati?
Yeah, I think it's a really interesting area within bladder cancer, and actually it's that, we could talk about biomarkers within bladder cancer for a whole day. Bladder cancer is sort of perfectly poised for a biomarker, because if you think about it, you've got urine, It is readily available. It's easily collected. You don't need to have a blood test. You don't need to have a camera, placed into your bladder. And urine obviously has direct contact with the bladder. And so all these things mean that there have been a deluge of urine-based biomarkers. However, as you alluded to, none of them are really used in clinical practice because they aren't they aren't good enough really to be used in all patients for clinical practice. But yes, there is a lot of research at the moment looking at specifically urine-based biomarkers, but also looking at biomarkers within the blood. So that's something called a liquid biopsy. So can you take a sample of blood from a patient and look at certain molecules or proteins within that might tell you whether a patient has say a recurrence, or maybe even a biomarker that gives you an idea of prognosis. So if you have this specific biomarker, this means that you may have a better or worse prognosis than someone who doesn't. One of the areas that's really taken off in bladder cancer is immunotherapy, which is which you mentioned before. And I think certainly when I was in medical school, it was a really big surprise to me that cancer is really all about the immune system. I really had no idea. And a large part of it is how tumors hide from the immune system, how they're attacked by the immune system. And one big area in immunotherapy is looking at a specific receptor called PD-1 or programmed death 1. So that's a receptor that sits on cells. And essentially what happens is when it binds a specific ligand, that tumor cell or that tumor then hides from the immune system, so the immune system can't attack it. However, if we then go and give patients drugs that will inhibit PD-1 or PD-L1, they're called checkpoint inhibitors, then the tumor can no longer hide from the immune system, and the immune system can attack it. That's it put very, very simply. It's a lot more complicated than that, but that's just a very simple explanation for it. And so in 2014, the FDA here in the US approved the first immunotherapy for bladder cancer. And that's just, opened up the floodgates. We are now looking at immunotherapy in lots of different settings. So the first approval for it was actually in advanced or bladder cancer, so bladder cancer that had metastasized and spread outside the bladder. But we're now looking at it at much earlier stages in the disease spectrum. So we're looking at these receptors in patients, for example, who are about to have a cystectomy or an operation to remove the bladder, to see whether if we give checkpoint inhibitors at that point, so that would be called the neoadjuvant setting, will they respond better? We're also looking at immunotherapy in the non-muscle invasive disease. So that's the bladder cancer that's confined just to the lining of the bladder. Now, what's interesting about this is that you would think, okay, brilliant, we found this amazing marker, we can look for it, and if we find it, we know we can give patient checkpoint inhibitors and they're going to do fantastically well. And it's really interesting because that is not the case at all. We know that only about 15 to 20% of people with PD-1 or PD-L1 respond to checkpoint inhibitors. And there are patients who don't exhibit these, but still have very good responses to immunotherapy. So there's clearly something else going on. It's, it's a complex environment in the tumor, and people are looking at other things like the tumor microenvironment and tumor mutational burden. So PD-1, PD-L1 is one part of the puzzle, but there are so many other parts. But that's just one example of the progress we've made in the last decade. And I think the next decade is going to bring a lot more markers and a lot more sort of things that we can target and look for specifically, so that patients have much more personalized care, because at the moment it's really sort of a one size fits all. But as we find out more and more about PD-1 and other tumor biomarkers, I'm hopeful that we will see very sort of individualized patterns of care for people based on the sort of molecular subtyping of the tumor. Larry, Aisha, I was going to ask you, when you were talking about your project, and I don't think I've spoken to you about this before, but I was wondering what specific cancers are you looking at and what specific markers?
Yeah, so that's a good question. So in the US, the project I'm working on, my Fulbright project was actually supposed to start this past year, and it's being delayed till next year. But the cancers I'm looking at in project in the US are breast, lung, and prostate cancers. And they're in very different stages of biomarker and diagnostic development. So for example, Niyati mentioned PD-1 and PD-L1. These are proteins that are exhibited in a small proportion, very important proportion of lung cancers, but it's this activity and what's going on in lung cancer is incredibly rapidly changing. And these markers are coming out and being cleared through the regulatory system almost monthly. I mean, these things are really happening, and they are combined sometimes with drug development, which is also very rapid in the lung cancer space. So trying to find out whether they've been effective. And one of my collaborators is named Carolyn Presley. She's at Ohio State. She looked at the use of these markers between 2010 and 2015 throughout the United States, using data from a particular database, not actually the SEER registries actually, but she looked at all the marker uses for lung cancer, had no effect on lung cancer mortality. So she and I are working with a team of investigators to try to find the right data set to see if that's changed over the past 5 years. The period between 2015 and 2020 has been very active, and she believes we've gotten better at targeting. But so as Niyati mentioned, it's not a guarantee. You can sometimes find these markers and they look like they'll be very effectively treated by certain therapies, certain immunotherapies in particular, but it doesn't always work out. The other two cancers, very different. Breast cancer is a much longer track record in biomarkers, and several of them actually have been used since before 2010. And some recent evidence from one of the most popular biomarkers, something called Oncotype DX. And this is not to criticize this marker directly, I just want to comment that only last year, an article came out in the United States that these markers, which appear to be quite effective for white women in the US, they're not nearly as effective for African Americans. And we've used these markers for 15 years, and it was only by having registry type data connected to biomarker data that Ken Hoskins at the University of Illinois, Chicago was able to look and see whether in fact these markers were effective in different subpopulations. It's one of the principal uses of the kind of health services research data that both Niyati and we lean on. And so we just discovered that these markers are not as effective for other populations. Prostate cancer, also interesting, a very long track record in the use of a particular biomarker, the blood biomarker, prostate-specific antigen, first approved for monitoring for prostate cancer actually in the 1980s by the FDA, but then rapidly used for screening before any evaluation of screening had been done. And that's been used now since about 1990, so that's over 30 years, but only recently are there new markers that are being used that are subtyping prostate cancers that can tell us a little bit more whether these are more lethal or not. A lot of prostate cancer is what's called indolent. And so trying to figure out which ones of the many prostate cancers that emerge are needing surgery or radiation therapy or needing surveillance. Actually, a lot of prostate cancers actually need active surveillance. So I'm looking at markers in different stages of where they are. And the UK uses them very differently than we use in the US. So I'm looking to collaborate with the folks at Cancer Research UK, who are my collaborators, to look at the ways in which these markers are becoming more and more used elsewhere outside the United States right now. And that's going to be a really fascinating area of study to see how the UK uses them, how that differs in their diagnostic approaches from the US. And that US-UK comparison has a long track record in health research that really then tell you about the ways in which we can improve the way our health systems deal with these cancers.
That's so interesting, and I can't speak about lung and or breast cancer, but I can certainly speak to prostate cancer. They would probably make up the majority of the patients I would see in clinic back at home. And I think the PSA is such a good example of a biomarker which isn't perfect. And just to sort of put that into context, maybe a little bit more for the audience, if it's interesting, typically men in the UK over a certain age are entitled to ask their primary care physician for a PSA. That's what Larry was mentioning, if they want to, but sometimes primary care physicians will test for it anyway. And so you have a patient that comes in to your clinic with a PSA reading, and they're often very worried that that PSA number means they have cancer. But and it's a whole conversation that you have with the patient that, well, first of all, we don't use the PSA in isolation. We just don't look at one number and say, based on that, you've got prostate cancer. We use it in combination with a physical examination of the prostate. And now in the UK, certainly, we're using it in combination with MRI scans of the prostate. But your PSA can be raised for a number of reasons. So if you have a urinary tract infection, if you've recently had an operation on your prostate, if you've had a catheter placed into your bladder or a cystoscopy, all of these can give you an elevated PSA. But those things aren't well known, and so often men will come in really worried that their PSA, whatever that value is, means that that is a diagnosis of prostate cancer. And the other thing I tell men as well is that it's often not just a single value. Sometimes we look at a trend. What we're doing more and more is looking at the size of the prostate and looking at the PSA relative to the volume of the prostate to give us an idea of whether it's worrying or not. But ultimately, if someone comes in with an abnormal PSA, that does commit you as the clinician to investigate that. And as I said before, that is in the UK, that would involve an MRI. But that is only something that's happened relatively recently. Prior to MRI, we were subjecting all of these men to prostate biopsies. And certainly, let me tell you, I'm very glad that I'm a woman and never need to have one of these because, they're not pleasant. The old-fashioned way of biopsying prostates is actually through the rectum. And if you think about it, it's not the cleanest area. It carries a risk of infection. So even though you give men antibiotics, this procedure still carries a risk of, pain, infection, bleeding. We've moved to a slightly newer technique of biopsying prostates in the UK, which involves taking them from a different area, not through the rectum. So we go through the perineum, which is the bit of skin that sits just above the rectum, between the scrotum and the rectum. And that's reduced our infection rates. However, you've still got discomfort, bleeding, other sort of symptoms that can happen afterwards, but also, you may not be targeting the right area of the prostate. So you may not be hitting the cancer, and you may be subjecting men to future biopsy. So if you're monitoring someone's PSA on an active surveillance program, which Larry mentioned, that typically involves looking at the PSA at regular intervals. If your PSA is going up, that would mean another biopsy. So I just thought I'd mention that because I think it's a good example of how, it's good, PSA is good, but it's not perfect, but it's the best we have. And we as clinicians have to learn how to interpret that test, use it in combination with lots of other factors. But ultimately, you always err on the side of caution. No one wants to miss a cancer diagnosis. So, if you see worrying patterns in PSA, you may choose to get a biopsy, and that may mean for the patient that they get a diagnosis and they go on to be treated, but it may also equally mean ongoing surveillance, further biopsies. And if we had a biomarker that was more sensitive and more specific, we could eliminate this for the patient altogether. And that's the goal, ultimately. That's why we do biomarker research, because we're in search of that one biomarker that can really optimize the patient experience.
You know, you mentioned something that I think the audience might have missed because it was so quick, that the technologies that we have to go in, for example, to a prostate and sample the tissue. So the biopsy takes little bits of tissue out of the prostate. You can take 2 or 3 or 20, and you could still potentially miss what's going on in the organ. It's one of the reasons why we look to things like imaging, where you could see the entire organ, like MRI that you mentioned, or we look toward the development of these biomarkers, which, if they are sensitive enough, could accurately capture what's going on with the tumor. One thing I have to ask you is, since you've now been here in the US, in Texas, for a while, what do you notice about the differences in the ways in which we approach the use of these various biomarkers in the diagnostic space? How is that different from what you do back at home?
I think I'm probably not in a good position to answer that question, because I haven't actually done any clinical work while I've been here. I have a sort of vague sense that, well, at MD Anderson, they are, you know, the nation's best cancer center. They're a huge research institution, and so yes, they do. You know, they do incorporate that as part of the patient journey in a way that we don't in the NHS. But as you sort of alluded to before, the UK does things very differently. Before we introduce any new technologies in the UK, it has to go through a sort of technology assessment by a regulatory body, NICE, and often one of the decisions or the factors that are involved in making a decision as to whether to bring something into the NHS or not is cost. So in the US, so one of the things I've been really interested to find out is that cost analysis is not required at all in the US by the FDA. In fact, the FDA do not look at cost. You know, if something is cost efficient or not, that does not play into the decisions that are made. So you end up in a situation where you've got, let's look at immunotherapy, for example. Immunotherapies cost in the region of hundreds of thousands of dollars. And we're now looking to see whether, well, actually, is that cost effective? And certainly, well, the answer is it's not. In a lot of cases, it's not. And that's why there are a lot of immunotherapies which are used in the US that aren't used in the UK. And that's purely from a cost point of view. It's not cost effective. And so, you know, a National Health Service can't fund that. So that's certainly an area which I don't think I knew about before I came here. And I've been really interested to learn about, because, you know, on one hand, I think the advantage of that is you're saying, well, whatever the cost of a drug is, if it could potentially extend this person's life, then it doesn't matter what the cost is. We should just allow that patient to have that drug. But actually, that does have some knock-on effects. If you take that sort of approach, what you're saying to pharmaceutical companies is that, you know, you can just charge whatever you want. And really, that is exactly what pharmaceutical companies have been doing, just charging extortionate amounts of money. And it's often, you know, they will argue and say, well, actually, we need to do that to cover our, you know, research and development costs of, you know, other drugs that we're developing, those drugs that work and those drugs that didn't work. But actually, there is some evidence to show that the cost of the R&D is just a small fraction of the profits that these companies are generating. So that's been really interesting for me to see. I don't know if you have any thoughts or sort of views on that, Larry.
I do. We get a little off the topic, but I think it's actually quite relevant because it actually spins back to diagnostics and what are called companion diagnostics with these drugs. So about the expenses, and I'll make just a couple of comments just so that the audience knows, is actually written into the statute, into law by Congress, that neither the Food and Drug Administration, which approves these technologies, drugs medical devices, et cetera. Diagnostics are medical devices. Or the major US funder of care, the Center for Medicare and Medicaid Services, they're not allowed to look at cost, and they're not allowed to look at cost effectiveness. And for those of us who are policy people like myself, Dr. Lobo, we're fascinated by the fact that there is a pretty clear dividing line what the regulatory and reimbursement agencies can and cannot look at. Now, that does not prevent, in the US, private insurance companies from making decisions on cost effectiveness. They don't have to cover certain things. They sometimes get sued in the US because of that. So it's a very, very different approach. And the diagnostics, I think, are part of that because they're actually the gateway to the use of certain immunotherapies and other very expensive drug therapies. So actually getting the diagnostics right is actually in part and parcel of getting the drug regimens right. Because if we do get the diagnostics right, and we know what subtype of cancer someone has, for example, whether they have the PD-1 protein or the PD-L1 pathway, which will help make a good treatment decision, you want to make sure that that's an accurate test. And that's really important. And that if it is an accurate test, that we can then connect the right therapies to it so that we actually are trying to do things that are more cost effective. Even though we don't require it, everybody is sensitive to not doing things for cancer patients just because you'd like to actually have them be effective at least and cost effective preferably. But the reimbursement and regulatory bar here is quite different. But getting the diagnostic technologies right for knowing what the cancer is and whether and when it'll recur, that's actually a very important key to managing and husbanding our resources, which we don't do all that well in the US, frankly. Partially, I think, Niyati, is because we have a large population and cancer, even common cancer, is relatively rare. So we tend to spread that risk over a large population. And so it's a little different here sometimes. And we don't have a national health insurance. And people don't see that if we put money into cancer drugs, we're not putting it into neonatal care, or we're not putting it into care for patients with end-stage kidney disease or something like that. We don't see these as one or the other. We try to do it all, which I think is not always effective. Let me ask you a very important question about what you mentioned earlier, and that's individualized treatment. And to what degree do you think we're entering an age where we really are trying wherever we can to use what people might call either personalized medicine or precision medicine? That must be something that you think about an awful lot clinically, and I suspect in your research as well.
I think that time is coming, and I think it's here already. For example, the PD-1, PD-L1, we do look at that for patients with bladder cancer, and so that's already there. But I think, certainly in my career, I'm just at the start of my sort of urological career, and I anticipate that by the middle of it, or certainly towards the end, that people will really be using precision medicine and individualizing care to patients, whether that's using, for example, in bladder cancer, there's been a lot of work looking at sort of panels of biomarkers to predict response to neoadjuvant chemotherapy. So before patients have a cystectomy, some patients will have chemotherapy before their operation. And the reason for that is the aim is by giving chemotherapy before surgery, you're treating any micro metastases. So those are metastases that are there, but they're too small for us to spot on imaging. So by giving this chemotherapy, you're essentially treating those. You may also have get downstaging of the tumor as well. So, and we have level 1 evidence that shows that patients that have neoadjuvant chemotherapy do have a survival benefit. But not everyone gets it, and not everyone responds to the neoadjuvant chemotherapy. So, for example, if you are giving patients neoadjuvant chemotherapy, you're delaying their cystectomy by a few weeks to allow them to have that drug. But if you fall into that category of patients that will not respond to the chemotherapy, what you've done is you've just delayed their cystectomy. And we know that patients have poorer outcomes if you delay cystectomy by about 12 weeks. So we know that. So really, we want to be able to identify those patients who will benefit from neoadjuvant chemotherapy. And so those are the ones that go on to get it, and those that don't go straight to surgery and don't have that diagnostic, that treatment delay. So currently there's a lot of work looking to identify panels of biomarkers. So not just one, but maybe 3 or 4, that if they're present within the tumor, that you can those are the patients you prioritize for treatment. So that is already happening. And I think that's, one of many, many examples. So I think, in the next 2-3 decades, we'll really start seeing sort of the practical application of this.
You hit on something really interesting there in that you said about sort of looking ahead and the practical applications of some of this research in the next 2 to 3 decades. And I guess we've talked a lot about what's happening at present over the last 45 minutes or so. And I'm really curious, what does the future hold for the study of cancer diagnostics and perhaps how that translates as well to patients as well? What are the frontiers that perhaps the casual observer should be paying attention to?
Go ahead, Niyati, go ahead.
So the future of diagnostics, as I think what we really want to aim for is, as I sort of mentioned previously, you want the perfect biomarker. That's all. Whether or not we'll get that, nothing is perfect. But if we can have, a biomarker that can prevent people from having invasive diagnostic tests, if we can rely more on imaging, for example, all these biomarkers, so patients don't have, the discomfort, that I think we'll see that. I think we hopefully will see more in the way of, I think, patient education, so that, and physician education, so we know when to refer patients, when to send patients to a specialist. But I think really with the diagnostic aspect, it's going to be the use of imaging, certainly. I think prostate cancer, we've seen that in a big way. That may or may not have some application in bladder cancer as well. We're waiting to see. But imaging and biomarkers, I think those 2 things are going to transform the way we do diagnostics in the future. What do you think, Larry?
I think definitely. I think we've seen some really dramatic improvements in the precision of imaging in a variety of areas, and I think it's going to get even better. I do think there's a 2-edged sword on the blood biomarkers, and I think you've mentioned it before, because we are getting better, we think, at detecting what's going on within a patient's body. But we know that especially in older persons, there's a reservoir of potential findings that could provoke action. And I think we have to be very careful we don't overwhelm the healthcare system by discovering very, very indolent tumors in people's bodies that are not likely to affect them for 1, 2, 3, 4 decades and begin treating them prematurely. So I think we have to balance that. That's one of the things that I think these marker investigations should maintain. I think they will do some of that in areas like the UK and Europe, where issues of cost and effectiveness are trying to balance what's going on in the health system with the marker discoveries is central. It'll happen a little bit less in the US, but I do think we're in an exciting time, because I think these markers are going to get better and better. And I think it'll be up to people like ourselves to watch to make sure that even as they get better, they're doing so in a way that is consistent with building a healthcare system that is smarter and a learning healthcare system. And that's the other thing I want to point to that I think is going to happen. We still are not great, US, UK, France, China, you name it, at using electronic medical records to inform us about what's going on in patient diagnostics and patient care and follow-up. And linking electronic medical records, what's happening in the healthcare system, to registries and to developing markers and treatment data and drug data, all of that together I think could be a really set of very, very powerful tools that'll help us look at the use of these technologies. And I think we're getting better at it, but still, it's a challenge. And I'll give you just one example. Right now in the US, we're trying to do these studies on breast and lung and prostate cancer. And many registries get data from these biomarker companies, or electronic medical records get them as PDFs. So someone in the biomarker company does the test, fills out information as if they were using a typewriter, takes that information and scans it as if it were a fax, and sends it to our local hospital and the clinician to read it. And putting that into the medical record and then using it as researchers is almost impossible. And why we're doing that in the year 2021 is crazy. It's absolutely crazy. These data should be developed with harmonized standards. Electronic medical records should get these data, in structured fashion, and then they could be used more actively, not just by an individual clinician making a decision for the patient, by researchers, so we can aggregate this across healthcare systems in the US, across communities and states, and be able to use these data. I think that's coming, but it amazes me still in the year 2021 that we're not there. And even with as good a system as the National Health Service has, they still have limitations in the way they can use data. And I think that's going to break free in the next few years. I really do think that there are technologies that are going to help us get over that hump. And I think that's going to be very important. So more and better data collection combined with what Niyati said, better use of imaging, more precision with these blood biomarkers and tissue biomarkers, I think is going to help us a lot. I know we're close to time. I want to turn it over to my great colleague, Dr. Lobo, who's now in Texas, in very warm Texas. And why don't you wrap us up?
I think I really enjoyed talking to you, Larry. I think what's so nice is I think you've got such a bigger picture view of things because you're looking at many different cancers, and I've got like a much smaller view because I treat only urological cancer. So it's been really nice and enlightening for me to sort of get that bigger picture view. And I guess at this point, are there any questions from the audience? We'd be happy to take them.
I think so. Oh, there's a question actually on the point that you just made, Larry, about people using PDFs still for data transfer. Are there textual analysis techniques that people can use to turn those into workable data?
There are now, actually only in the last couple of years, and I'm working with a couple of companies, one company actually in the UK, who now can do what they call shallow matching, and they can take the PDF and they can convert it into text and then convert that text into structure. But it's actually not trivial, and mining the data in the text fields, even once you've converted the PDF and putting it into structured data, is really still hard. And we combine algorithms, artificial intelligence, and natural language processing, but it's not as good as it can be. And the SEER registries, in fact, that Niyati mentioned earlier, are now contracting with companies specifically. If we could take all these PDFs and just snap our fingers and say, oh, we'll turn it into data, then we would. But the way the registries are doing it is they're going to the companies and saying, let's work out a structured data format so you can send it to us electronically, as in research quality data. And what we would need to use in research quality data has a higher bar than what you would need as a clinician. So these techniques do exist, and they're going to get better, but I think we can even do better as a health system to agree on data items.
That makes a lot of sense. And then it's a really interesting question as well that's just come in, if we've still got time, which is on protecting privacy when sharing medical records. How are these kind of documents and data anonymized? And I suppose it's a crucial interest, I guess, in the UK as well. If we think about something like GDPR as well, the way that we have that right to not have certain data held as well.
So most of these data systems in the registries have a very high level of protection behind firewalls. They collect data that are very identified, and then all researchers get them only as de-identified data. You almost never will get a data set that has personal health identifiers, PHI, in them. And they're not necessary. They are absolutely necessary for registries to track them over time. It's one of the reasons that the laws are there, and you actually can't violate those laws in terms of in identifiers. That comes with huge penalties. So we're quite careful about that. Identifiers are necessary to build the data, but not necessarily to do research on the data.
Yeah, and when I was applying to get all my data from SEER, the amount of paperwork you have to do, and ensuring that patients are not identified is huge. And there are all sorts of restrictions. Once you've done your project, you need to ensure all the data is completely destroyed. So there are lots of mechanisms in place to make sure that patient identity is protected.
Makes sense. Thank you so much, both of you, as we hit 6 o'clock. This has been fascinating, and I've really learned a lot, and I hope the audience at home has as well. So thank you, Larry. Thank you, Niyati. I hope the day ahead is really great for both of you. Have a great rest of the week. And if you've enjoyed this at home, be sure to find us on our website, where you can find out information about our upcoming events. We've got one more across the pond in our first series coming up in a couple of weeks' time. That will be on the 14th of September, where we're talking about advocacy in education and healthcare. But until then, have a great week, stay safe, and we'll see you all next time. Goodbye.
Thanks. Bye.
Thank you.